What psychiatrists are silent about when treating insomnia, they are silent about cognitive behavioral therapy. They mainly talk about preparations of hypnotic tranquilizers, antidepressants, or neuroleptics. Watch this video to the end and you will find out why most insomniacs do not need and sometimes cannot be treated with any psychoactive drugs, and why exactly with conditioned reflex insomnia, drugs can be contraindicated. And 60 to 70% of those insomniacs, it's chronic conditioned reflex insomnia. My name is Roman Buzunov. I'm a sleep doctor, professor, doctor of medical sciences. For nearly 3 decades, I have diagnosed and treated insomnia, snoring, apnea, and other sleep disorders. So the prescription of drugs by psychiatrists, to a significant extent, it's not their fault, but their misfortune, as well as actually neurologists and other specialists who finished medical institutes earlier and now universities. We still do not teach classical somnology at medical universities. We don't have such a course. We talk a little bit about how a person sleeps in physiology, and then pharmacology, neurology, psychiatry start. And there the older colleagues tell the teachers, students, that mainly you need to treat insomnia with pills. What's the problem? The thing is, we have more than 60 sleep disorders. They say everyone is sick, just some are undiagnosed. And for instance, in the case of sleep apnea, the use of sleeping pills and other similar drugs is contraindicated because it potentially exacerbates the apnea and can even increase the severity. Tablets are contraindicated, for instance, in restless leg syndrome. If antidepressants and neuroleptics are prescribed, they can potentially even worsen the course of restless leg syndrome or periodic limb movement disorder in sleep, because antidepressants and neuroleptics have a class-dependent effect of exacerbating restless leg syndrome. But how does the educational process work? A man came to the institute, and in the institute, they didn't really tell him that there are a lot of sleep disorders and a lot of different causes for these sleep disorders. And so such a person decides that he will specialize in psychiatry. He goes to a psychiatry residency where older colleagues, who also weren't taught sleep medicine, tell him that sleep disturbance is a symptom of some psychiatric disorder. That is, any sleep disturbance, older psychiatrists attribute to some psychopathological syndrome or disease. Schizophrenia, acute psychosis, neurosis, bipolar disorder, recurrent depression, generalized anxiety disorder, and so on and so forth. And unfortunately, psychiatrists do not know that, for example, insomnia can be due to a deficiency of vitamins B or D. That insomnia can be related to a lack of iron in the body or magnesium, or the same syndromes of obstructive sleep renewal and periodic limb movement syndrome in sleep can cause severe insomnia. And therefore, any sleep disorder, a psychiatrist incorporates into his psychiatric diagnosis and prescribes, accordingly, medications. But rather, I would say, of course, there is a zone of responsibility of psychiatrists if it is a psychiatric illness. And in this sense, a symptom of sleep disturbance is, for example, a symptom of depression, early awakening with the inability to fall asleep again, or, for example, difficulty falling asleep with generalized anxiety disorder. Yes, there you can treat accordingly the main disorder and think that the symptom of insomnia will go away. But if we take the classic development of chronic insomnia, it is known that 3 months of some real cause is enough, which causes insomnia. Even, for example, as depression, anxiety, or some psychiatric problems, or somatic problems, or some other problems, just ongoing stress. A person develops chronic conditioned reflex insomnia with established fear reflexes of not falling asleep. Bed insomnia. That is, a person desperately wants to sleep, goes to bed, lies down. And right there, sleep disappears, as they say, like a hand removed. Maladaptive thinking and behavior. That is, a person thinks, oh my God, I have insomnia, so I slept poorly today, tomorrow I will sleep even worse. And here, a healthy person thinks, if I slept poorly, I will sleep better tomorrow. Here is the difference in thinking. Maladaptive behavior, you need to lie longer, try to get enough sleep, and a person begins to lie in bed longer. He starts having restrictive behavior, thinking he slept poorly and won't go to work, canceling meetings, lying down, suffering, and not even exercising. And this triad, the reflex of fear of not falling asleep and bed insomnia, negative thinking and forecasting, and maladaptive behavior, this is the self-sustaining situation with insomnia. It no longer matters what caused the insomnia. After 3 to 4 months, these conditioned reflex components join in, and insomnia becomes absolutely self-sustaining. It doesn't matter what caused it. And, by the way, the same psychiatrists write in their textbooks that insomnia is most often a residual symptom of the treatment of anxiety or depression. And they think it's untreated insomnia or anxiety, and let's continue to treat with antidepressants and neuroleptics. But the latest clinical recommendations of the European Society for the Study of Sleep Disorders say that if you have a comorbid but coexisting situation with anxiety, depression, and especially chronic insomnia, then chronic insomnia needs to be treated according to its own laws. It is impossible to cure it with drugs. This situation is also understandable. If our insomnia is supported by conditional reflexes, negative thinking, and maladaptive behavior, then pills do not cure this. They do not treat conditional reflexes. Additionally, a conditioned reflex of fearing sleep without medication develops. It's enough to take any pills for literally a month. A psychological dependence will develop. A person will already be afraid to fall asleep without this pill. And then physical dependence will develop. And then side effects will start to develop with increased dosages of drugs. And the question of their cancellation arises. But it turns out that we did not eliminate the cause of chronic insomnia in the form of negative thinking reflexes and maladaptive behavior. In addition, they caused another conditioned reflex of psychological dependence on taking a pill. And if we cancel the pills, if physical dependence has already developed, then we get rebound insomnia, plus all these reflexes flare up. Oh, I won't drink the pill, I won't fall asleep. And everything returns literally right after the cancellation of the drug. And sometimes it gets even worse than it was before the drugs were prescribed. Because here the psychological and physical dependence on sleeping pills, tranquilizers, or antidepressants is added. And it turns out that after some time, it becomes impossible to cancel the drugs. A person becomes chronically dependent, that is, becomes a drug addict. And therefore, in this situation, and this, as I said, is more than half of such insomniacs, of course, we need to conduct a thorough examination. We need to clarify psychiatric problems. And maybe the person really has a major depressive episode, generalized anxiety disorder, or bipolar disorder. We need to physically examine the person, take hormones, vitamins, trace elements, and so on. We need to look at the lifestyle and fill out a daily log of this patient's sleep. But if we don't see any psychiatric or somatic problems, then usually it's chronic conditioned insomnia. And dear friends, since 2017, cognitive behavioral therapy for insomnia has become the first line of treatment for such chronic insomniacs. And psychiatrists are not taught it. Well, rather, I would say that some individuals, so to speak, advanced people who read international guidelines and constantly improve their qualifications, they might know about this and even apply some elements. But this is a separate large block of work. You know what? If a person didn't learn much in the institute, then didn't really go through qualification improvement, has been treating with drugs for 20 years, even if he hears some new information somewhere. But unfortunately, such rigidity of medical thinking of a doctor is one of the most serious problems slowing down the development of medicine. I've been treating like this for 20 years. It somehow helped, and I will continue to help in the same way. And I won't introduce anything new. Unfortunately, that's how it happens with doctors too. And since psychiatrists have not learned to treat with cognitive behavioral therapy, which is another 60 or even more % of all chronic insomniacs, they will continue to treat it accordingly with their psychopharmacological preparations. Let me underline once again that in most cases, a psychiatrist will not cure such insomnia. And what's more, it may even cause physical and psychological dependence. So, dear friends, I have a very good relationship with my psychiatrist colleagues, and if I suspect any psychiatric illness, I always consult with my colleagues, and they may even take over later, because I am not a specialist in treating psychiatric problems or, for example, recurrent depression with suicidal thoughts or severe psychosis. naturally a psychiatrist is needed. But at the same time, if we are talking about conditional reflex insomnia, there is no psychiatry involved. And pharmacology in general should not be particularly involved there either. And cognitive behavioral therapy is just perfect for eliminating conditional negative reflexes, negative thinking, and maladaptive behavior. And I implement a 6-week cognitive behavioral therapy program for insomnia, which allows most patients to cure long-standing, sometimes decades-long insomnia in 6 weeks. And my main task in this sense is not to prescribe drugs, but even if a person takes drugs, to apply drug withdrawal techniques again within the framework of the cognitive behavioral therapy program for insomnia. So, dear friends, I'll say this: if you have chronic insomnia, it's better to go to a sleep specialist or even a psychiatrist who understands, has undergone some specialization in the field of sleep medicine, understands that there are not only psychiatric causes of sleep disorders, and is ready accordingly to diagnose and treat them. But in the hands of a sleep specialist, as a rule, there is a full spectrum or set of possible diagnostic capabilities. The psychiatrist arrived, assessed, diagnosed, and promptly prescribed treatment. If you came to a psychiatrist with chronic insomnia and he prescribed treatment without examination, unfortunately, this could be a serious mistake. Once again, consider somatics, vitamin and microelement deficiencies, hormonal imbalance, etc. You need to look at the lifestyle, at the established reflexes, and do polysomnography if there are suspicions of any sleep disorders, apnea, hypoxia, sleep movement disorders, and so on. And only by making a diagnosis, acting on the cause, can you get rid of even chronic insomnia that has lasted for many years, not just giving everyone sleeping pills in a row. So it turned out perhaps quite an emotional speech, but I will say that when patients come to me who tell me that they just had a couple of weeks of insomnia and they don't describe any psychiatric symptoms, but they go to a psychiatrist and he prescribes them 2 or 3 drugs at once, an antidepressant, a neuroleptic, a conflict resolver, then, it's better, of course, to go to a specialist who will first conduct an examination, first then make a diagnosis, and only then prescribe treatment. Good night to all of you.